Welcome to your Q&A review for the ATI Maternal Newborn exam. We'll work through real exam-style questions, explaining why each answer is right, why others are wrong, and the theory behind it. Today we're covering Section 1, Antepartum care, including contraception and family planning, physiologic changes of pregnancy, prenatal visits and lab testing, danger signs and fetal monitoring, prenatal nutrition and weight gain. Our website offers free exam guides and practice questions to help you ace your ATI Maternal Newborn exam. Everything you need is just a click away, so don't wait. Follow the link below, grab these resources, and start studying smarter toward passing with confidence today. All right, let's get started. Question 1. A nurse is counseling a client who wants the most effective, reversible method of birth control. Which method should the nurse recommend? Your options are A. An intrauterine device, B. A diaphragm, C. The calendar method, D. Male condoms. Which one is it? Pause the video if you need more time. The correct answer is A, an intrauterine device. A is correct because long-acting reversible methods such as the intrauterine device are the most effective because they work continuously and do not depend on the client remembering to act each time. B is wrong because a diaphragm works only when fitted properly and paired with spermicide each time, so its real-world effectiveness falls below an intrauterine device. C is wrong because the calendar method relies on predictable cycles and careful timing of abstinence, which makes it one of the least dependable options. D is wrong because condoms guard against sexually transmitted infections but carry a higher failure rate since protection depends on correct use during every act. The most effective reversible birth control methods share one trait. Once in place, they keep working without any daily effort. This is long-acting reversible contraception, and the intrauterine device, or IUD, sits at the top of the list. Effectiveness is measured two ways: perfect use and typical use. Methods like pills and patches falter in typical use because people forget doses, but the EUD requires no daily action. So its typical and perfect use failure rates both stay under 1%. Two versions work differently. The copper IUD releases copper ions that create a toxic environment for sperm, while the hormonal IUD releases progestin that thickens cervical mucus, thins the uterine lining, and often suppresses ovulation. Copper devices last 10 to 12 years, hormonal ones 3 to 8. Sterilization is just as effective, but it's permanent. The moment a question asks for the most effective method a person can later stop to regain fertility, permanent options are disqualified, leaving the IUD as the answer by definition. Watch for signal words, most effective, reversible, long-acting, or any phrase about not depending on memory. Only the IUD pairs top-tier effectiveness with easy reversibility, and that exact pairing is what these questions test. Question 2. A nurse is teaching a client how to use a diaphragm for contraception. Which statement by the client indicates an understanding of the teaching? Your options are A. I do not need spermicide, B. I can leave it 3 days, C. I leave it 6 hours after sex, D. I will refit it for new brands. Take a second. Which answer would you pick? The correct answer is C. I leave it 6 hours after sex. C is correct because the diaphragm must stay in place at least 6 hours after intercourse, so any sperm are no longer able to fertilize. Then be removed within a day to limit infection. A is wrong because spermicide goes inside the dome and along the rim with every use. Without it, the device is far less reliable. B is wrong because wearing the diaphragm longer than a full day sharply raises the risk of toxic shock syndrome, making a 3-day span unsafe. D is wrong because refitting is based on a major weight change, a pregnancy, or pelvic surgery rather than simply switching to a different brand. The diaphragm works by pairing a physical barrier with spermicide, and its safe use depends on strict timing rules on both ends. The dome physically blocks sperm from reaching the cervix, while spermicide chemically disables any that slip around the rim. Neither piece works reliably alone, which is why correct technique matters so much. The timing rules run in two directions. Leave the diaphragm in for at least 6 hours so the spermicide can finish disabling sperm, but remove it within 24 hours to avoid trapping bacteria and risking toxic shock syndrome. The diaphragm is sized to seal against the vaginal walls and cover the cervix completely, with spermicide placed inside the dome and along the rim before insertion. Fit is the other pillar of safe use. A weight change of about 10 pounds or more, a pregnancy and birth, or pelvic surgery all change the body's dimensions and require a professional refitting, but switching spermicide or lubricant brands does not. Question 3. A nurse is reviewing the cervical mucus method with a client who wants to avoid pregnancy. Which mucus finding should the nurse explain marks the most fertile time? Your options are scant dry mucus, B. absent mucus, C. thick and pasty mucus, D. clear stretchy mucus. Before I reveal it, which one do you think is right? The correct answer is D. Clear stretchy mucus. D is correct because around ovulation, estrogen makes cervical mucus thin, clear, slippery, and stretchy like raw egg white, which helps sperm survive and signals the most fertile days to avoid. A is wrong because A scant, dry sensation reflects the low estrogen part of the cycle rather than the peak fertility the client needs to recognize. B is wrong because the absence of mucus indicates an infertile phase, so intercourse then carries little chance of pregnancy. C is wrong because thick, pasty mucus appears outside the fertile window, when the cervix is less hospitable to sperm and conception is unlikely. The cervical mucus method reads a woman's own body for signs of fertility, tracking how estrogen and progesterone reshape cervical mucus across the cycle, so a careful observer can spot the days when conception is most likely. Around ovulation, rising estrogen turns mucus thin, clear, slippery, and stretchy like raw egg white, helping sperm survive and reach the egg. After ovulation, progesterone takes over and turns mucus thick, cloudy, sticky, and scant, signaling that the fertile door has closed. The trap in these questions is direction. It feels intuitive that dryness signals something important, but the opposite is true. Peak fertility lines up with wet, stretchy, egg white mucus, not dry days, and reversing this gets the answer backward every time. Students often confuse this with its cousins. The calendar method predicts fertility from cycle length, and the basal body temperature method confirms ovulation after it happens with a sustained temperature rise. The mucus method is unique because it reads fertility in real time, with the egg white texture as its defining fertile marker. So whenever a question describes clear, slippery, stretchy, egg white mucus, that marks peak fertility, while thick, pasty, or absent mucus points to an infertile phase. Question 4. A nurse is teaching a client about latex condoms as a contraceptive method. Which client statement indicates a need for further teaching? Your options are A. I can use baby oil as lubricant. B. Condoms help protect against infections. Sir, I will check the expiration date. D. I will leave space at the tip. What's your answer? Commit to one before I continue. The correct answer is A. I can use baby oil as lubricant. A is correct because oil-based products like baby oil weaken latex and cause it to break. So the client needs only water-soluble lubricants, signaling that this statement requires correction. B is wrong because latex condoms do reduce transmission of most sexually transmitted infections, making this an appropriate understanding rather than an error. C is wrong because checking the expiration date is correct teaching, since an expired condom is more likely to tear and fail. D is wrong because leaving an empty space at the tip creates a reservoir for semen and lowers the chance of breakage, so this statement is accurate. A latex condom only works if the latex itself stays intact. Every rule of correct use exists to protect that thin barrier from tearing, weakening, or slipping. Only water-based or silicone-based lubricants are safe with latex because oil breaks it down. Checking the expiration date matters since latex grows brittle with age and heat. Leaving space at the tip prevents a rupture. And proper storage plus never reusing a condom round out safe technique. Oil-based products like baby oil, petroleum jelly, and lotions degrade latex within minutes, thinning it until it tears under normal use. That is why oil and latex should never appear together. These questions use negative phrasing, asking which statement needs further teaching. A learner can recognize several correct habits and still miss the point if they don't spot the one incorrect belief that oil-based lubricant is fine with latex. Condoms are highly effective, but only when the latex stays intact. Whenever oil-based products appear alongside a latex condom, that is almost always the failure point the question wants you to catch. Question 5. A nurse is caring for a client who uses an injectable progestin for contraception every few months. Which point should the nurse include in teaching? Your options are: A. Fertility returns within 1 week. B. It protects against sexually transmitted infections. C. Massage the site after the injection. D. Keep up calcium and weight-bearing exercise. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Keep up calcium and weight-bearing exercise. D is correct because injectable progestin can lower bone density over time. So the nurse encourages adequate calcium intake and weight-bearing activity to help protect the client's bones during use. A is wrong because the return of fertility can be delayed for many months after the last injection, not within a single week. B is wrong because this method prevents pregnancy only. The client still needs condoms to lower the risk of sexually transmitted infections. C is wrong because rubbing the site speeds absorption and shortens how long the dose lasts, so the client should leave the area alone. Let's dig into the theory behind the injectable progestin, a shot given every 11 to 13 weeks that works mainly by suppressing ovulation, with backup effects of thickening cervical mucus and thinning the uterine lining. The defining teaching point is bone health. This dose of progestin lowers estrogen, and estrogen normally helps the skeleton hold on to calcium. Over time, this can reduce bone mineral density, though it's largely reversible after stopping. So calcium, vitamin D, and weight-bearing exercise like walking are key counseling points. The technical detail worth remembering is the injection site itself. The dose is designed to absorb slowly from muscle over the entire interval between shots, so the site is left alone and never massaged, since rubbing speeds absorption and can leave a gap in protection. 2 more points follow from how the drug behaves. Because it releases slowly, ovulation can take many months to return after stopping, which matters for anyone planning pregnancy, and since it's progestin only, it offers no protection against sexually transmitted infections, so condoms are still necessary. This cluster of details sets the injectable apart from the combined pill and the implant, the every 3-month schedule, the bone density concern, the delayed return of fertility, and the instruction to leave the injection site undisturbed. Question 6. A nurse is teaching a client about combined oral contraceptives. Which client statement indicates a correct understanding of when to seek care? Your options are: A. I should take them only when needed. B. I will stop them for acne. C. I will report chest or leg pain. D. Spotting means they are not working. Which would you go with? Lock it in before the reveal. The correct answer is C. I will report chest or leg pain. C is correct because estrogen raises the risk of clots. So chest pain, shortness of breath, or leg pain can signal a serious clot and must be reported to the provider right away. A is wrong because combined pills work only when taken consistently every day. Taking them occasionally leaves the client unprotected. B is wrong because combined pills often improve acne rather than worsen it, so this is not a reason to stop taking them. D is wrong because breakthrough spotting is a common early side effect that usually settles, not a sign the pills have failed. Combined oral contraceptives contain estrogen and a progestin, and estrogen makes blood more prone to clotting. Because a small number of users can develop dangerous clots, nurses rely on a simple mnemonic to catch emergencies early. H stands for abdominal pain, chest pain or shortness of breath, headache, eye problems, and severe leg pain. Each one is a signal that estrogen-driven clotting may be underway somewhere in the body. A clot that forms in a deep leg vein can break loose and travel to the lungs, causing chest pain and breathlessness. A clot or bleed in the brain instead produces headache or vision changes, which is why these particular signs made the list. Nausea, breast tenderness, mild breakthrough bleeding, and mood changes are common and usually settle on their own. But chest pain and severe leg pain map directly onto the two most dangerous clot destinations, the lungs and the deep veins, so they'll always demand urgent evaluation. The combined pill's identity is its estrogen-driven clotting risk, unlike the progestin-only minipill. When a question mentions chest pain, leg pain, severe headache, or vision changes, it's testing whether you recognize a thromboembolic emergency. Question 7. A nurse is teaching a client who will start the contraceptive patch. Which instruction should the nurse include? Your options are: A. Apply to the upper arm. B. Apply to the breast. C. Reapply after every shower. D. Replace it once a month. Don't overthink it. Which one feels right? The correct answer is A. Apply to the upper arm. A is correct because the patch is placed on clean, dry skin over areas such as the upper arm, abdomen, buttock, or torso, and it can stay on during bathing and swimming. B is wrong because the patch is never placed on the breast, since that site can expose breast tissue to higher hormone levels. C is wrong because the patch is designed to stay in place through bathing and swimming, so reapplying after each shower is unnecessary. D is wrong because the patch is changed weekly for 3 weeks with a patch-free 4th week, not once a month. The contraceptive patch delivers estrogen and progestin through the skin, giving the same protection as a combined pill without a daily dose. Because it works transdermally, correct placement is the key detail these questions test. The patch goes on clean, dry, intact skin at one of 4 approved sites: the upper outer arm, the abdomen, the buttock, or the upper torso. The nurse rotates sites each week and avoids lotion, powder, or makeup so the adhesive bonds properly. One site is firmly excluded, the breast. Breast tissue is sensitive to estrogen, so hormone is never delivered directly over it, even though the surrounding torso is an approved location. The schedule mirrors the pill's monthly rhythm: a new patch each week for 3 weeks, then a patch-free 4th week when withdrawal bleeding occurs. Because it's changed weekly instead of daily, and stays adhered through showering, bathing, and exercise, It's harder to miss a dose. The patch's identity is transdermal delivery, weekly changes with a patch-free week, and a firm rule against placing it on the breast. That's exactly what these questions test. Question 8. A nurse is reviewing emergency contraception with a client after unprotected intercourse. Which statement by the client indicates correct understanding? Your options are: A. It ends an existing pregnancy. B. I can skip it if fine. C. It protects me for the month. D. I should take it within 3 days. Got a guess? Lock it in. The correct answer is D. I should take it within 3 days. D is correct because emergency contraception works best when taken as soon as possible and within about 3 days of unprotected intercourse, because it acts mainly by preventing or delaying ovulation. A is wrong because emergency contraception does not disrupt or end a pregnancy that has already implanted. It works before fertilization or implantation occurs. B is wrong because feeling well says nothing about the risk of pregnancy, so the client should still take the dose promptly to be effective. C is wrong because the dose addresses a single episode of unprotected sex and offers no ongoing protection for the rest of the month. Emergency contraception is a backup method used after unprotected intercourse or a contraceptive failure, and its defining feature is that it's time sensitive. The sooner it's used, the better it works, so teaching centers on acting quickly and knowing each method's effective window. The most familiar pill, levonorgestrel, works mainly by delaying ovulation so no egg is released to meet sperm. It's most effective within 72 hours, or 3 days, and retains some effect up to 120 hours, or 5 days, though its power fades with time. Ulipristal, a second option, holds its effectiveness closer to a full 5 days. A crucial point prevents a common misunderstanding. Emergency contraception works before fertilization by keeping egg and sperm apart. If implantation has already occurred, these methods do not disrupt it and will not harm a developing embryo. The copper intrauterine device is the most effective emergency option of all. Placed within 5 days of unprotected intercourse, it prevents the vast majority of pregnancies and then continues as ongoing contraception for years, making it ideal for someone who also wants long-term birth control. Watch for signal phrases like after unprotected intercourse, morning after, and within a certain number of hours or days. Remember, emergency contraception's identity is postcoital timing, a mechanism that delays ovulation, a 3-day best use window, and the fact that it never disturbs an established pregnancy. Question 9. A nurse is caring for a client who has an intrauterine device in place. Which finding should the nurse teach the client to report to the provider? Your options are: A. Fever with pelvic pain. B. Feeling the string after menses. C. Mild cramping on the first day. D. Light spotting between periods early on. Which one is it? Pause the video if you need more time. The correct answer is A. Fever with pelvic pain. A is correct because fever combined with pelvic pain can signal pelvic infection, a serious complication of an intrauterine device, so the client should contact the provider without delay. B is wrong because the client is taught to check for the string each month, feeling it is reassuring rather than a problem to report. C is wrong because brief cramping shortly after insertion is expected as the uterus adjusts and does not by itself require provider notification. D is wrong because irregular spotting is common in the first few months and usually settles, so it is not an emergency finding. An intrauterine device is safe and effective, but knowing which symptoms are normal versus which signal danger is a critical nursing skill. A helpful mnemonic is pains, period irregularities, abdominal pain, infection signs, not feeling well with fever, and string changes. Each letter flags something the client should report to their provider right away. The device and its strings can give bacteria a path upward into the upper reproductive tract, causing pelvic inflammatory disease if fever and pelvic pain go unaddressed. In the first months, mild cramping and light spotting are expected, especially with the copper device, but fever paired with pelvic pain and foul discharge is never routine. It signals possible infection and needs prompt evaluation. The same organ can tell two very different stories. Recognizing fever with pelvic pain as the reportable finding is exactly what these questions reward. Question 10. A nurse is teaching a client who had a vasectomy 1 week ago. Which instruction should the nurse include? Your options are: A. Reversal is simple and reliable. B. You are sterile immediately. C. Use another method until sperm clears. D. Avoid all activity for a month. Take a second. Which answer would you pick? The correct answer is C. Use another method until sperm clears. C is correct because sperm remain in the system for a while after a vasectomy, so the client must use another contraceptive method until semen testing confirms that no sperm are present. A is wrong because a vasectomy is meant to be permanent, and reversal is a complex, costly procedure that is not always successful. B is wrong because sterility is not immediate. Remaining sperm must be cleared through repeated ejaculations before the procedure is fully effective. D is wrong because most clients resume routine activity within a couple of days, using scrotal support and rest only briefly for comfort. A vasectomy cuts or seals the vas deferens, the tubes that carry sperm from the testicles to the urethra. But there's a critical catch every test question hinges on. Cutting the tube doesn't mean instant sterility. Even after the tubes are cut, a reservoir of sperm remains downstream in the tubing and glands beyond the surgical site. Those leftover sperm can still cause pregnancy for weeks, so the man is not immediately sterile. The couple must keep using another reliable contraceptive method until the reservoir clears. That typically takes around 12 weeks or 15 to 20 ejaculations, and it's only confirmed by a semen analysis showing 0 sperm. Picture a man 1 week post-op who feels fine and assumes he's sterile. His nurse corrects him. He's still fertile until a semen analysis, usually around 12 weeks later, confirms no sperm remain. Don't confuse the procedure with instant protection or with female tubal sterilization. The correct answer always ties safety to a documented negative semen analysis, not to healing time or how many weeks have passed. Question 11. A nurse is teaching a client who takes a combined oral contraceptive about warning signs to report. Which symptom should the nurse emphasize as most urgent? Your options are: A. Slight weight change. B. Sudden severe leg pain. C. Mild nausea in the morning. D. Breast tenderness. Before I reveal it, which one do you think is right? The correct answer is B. Sudden severe leg pain. B is correct because sudden severe leg pain can indicate a blood clot, a dangerous estrogen-related complication. So the nurse stresses that the client must report it to the provider immediately. A is wrong because a small change in weight is a frequent, harmless side effect rather than a sign of a serious complication. C is wrong because mild nausea is a common, early side effect that often eases when the pill is taken with food or at bedtime. D is wrong because breast tenderness is an expected hormonal effect that usually lessens over the first few cycles of use. Combined oral contraceptives come with a list of warning signs, but not all of them carry equal weight. The real skill being tested is prioritization, not just recognition. Sudden, severe pain in one leg is the classic red flag because it signals a deep vein thrombosis, a clot lodged in the calf or thigh. That clot can break loose, travel through the venous circulation to the heart, and lodge in the pulmonary arteries as a pulmonary embolism, an event that can be fatal within minutes. The mechanism is explained by Virchow's triad: sluggish blood flow, injury to the vessel lining, and blood that clots too readily. Estrogen tips that third leg of the triad by raising clotting factors, and smoking or immobility push the risk even higher. Nausea, breast tenderness, and spotting are common and benign. Headache or vision change is serious and points toward the brain. But sudden, severe, one-sided leg pain tops the list because it signals a clot that could embolize right now. When a question asks which symptom to prioritize, it's testing whether you can rank signs by how quickly they can turn deadly, and the leg clot always comes first. Question 12. A nurse is teaching a client about the progestin-only mini pill. Which statement by the client indicates correct understanding? Your options are: A. I take it the same time daily. B. I can skip a day safely. C. It protects against infections. D. I can take it any time. What's your answer? Commit to one before I continue. The correct answer is A. I take it the same time daily. A is correct because the mini pill works at a low progestin dose, so taking it at the same time every day is essential to keep cervical mucus thick and prevent pregnancy reliably. B is wrong because A, missed or late mini pill quickly lowers protection, so the client should use a backup method if a dose is delayed. C is wrong because the mini pill prevents pregnancy only and gives no protection against sexually transmitted infections. D is wrong because timing is strict with this pill. Varying the hour reduces its effectiveness, unlike the more forgiving combined pill. The progestin-only pill, or mini pill, contains no estrogen, and that single difference shapes everything about how strictly it must be taken. Its main mechanism is thickening cervical mucus so sperm struggle to cross, while also thinning the uterine lining and, in some cycles, suppressing ovulation. Because the mucus effect is short-lived, timing becomes the make or break feature. The cervical mucus thickens within hours of a dose, then starts thinning again as progestin levels fall, often before a full day has passed, leaving only a narrow margin before the next pill. The mini pill must be taken at the same time every day within about a 3-hour window. A pill taken later than that counts as a missed dose, requiring backup contraception for the next couple of days, a strictness the estrogen-containing combined pill does not demand. That precision is the trade-off for avoiding estrogen's clotting risk, making the mini pill ideal for breastfeeding patients or those with clot history. Remember, the mini pill's protection lives and dies by the clock. Question 13. A nurse is assessing a couple seeking an infertility evaluation. Which test should the nurse expect to be done first? Your options are: A. Hysterosalpingography, B. Laparoscopy, C. Endometrial biopsy, D. Semen analysis. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Semen analysis. D is correct because semen analysis is usually the first study because male factors cause a large share of infertility, and the test is simple, low cost, and non-invasive compared with female testing. A is wrong because tubal dye studies are more involved and are scheduled after simpler tests, once an initial semen analysis has been reviewed. B is wrong because laparoscopy requires anesthesia and is reserved for later evaluation, not the opening step of a workup. C is wrong because endometrial sampling is a more invasive female test that follows, rather than precedes, the basic semen analysis. An infertility evaluation always moves from simple and cheap toward complex and invasive, and that logic tells us exactly which test comes first. The semen analysis is the least invasive test available, asking nothing physically demanding of either partner, since male factor contributes to roughly a third of infertility cases, and nearly half when combined with other causes. It makes sense to rule this out before anything invasive. The full workup builds outward step by step. A thorough history and physical exam comes first, then the semen analysis, then confirmation that the woman is ovulating through cycle tracking or hormone levels. A semen analysis simply examines a collected specimen for sperm count, motility, and shape, offering a quick, painless window into male fertility. Infertility is defined as no conception after 12 months of trying, or 6 months if the woman is over 35. That definition explains why the workup escalates carefully, starting with the simplest, most revealing test, the semen analysis. Question 14. A nurse is preparing a client for a hysterosalpingography to evaluate infertility. Which assessment is most important before the procedure? Your options are A. Recent weight history, B. Family history of cancer, C. Allergy to iodine or shellfish, D. Bowel sounds. Which would you go with? Lock it in before the reveal. The correct answer is C. Allergy to iodine or shellfish. C is correct because the procedure uses an iodine-based dye to outline the fallopian tubes, so the nurse must first check for an allergy to iodine or shellfish to prevent a reaction. A is wrong because weight history does not affect the safety of the dye study and is not the priority assessment beforehand. B is wrong because A. Family cancer history, while useful background, does not pose the immediate safety concern that a dye allergy does. D is wrong because bowel sounds are unrelated to a tubal dye study and would not change how the procedure is carried out. Hysterosalpingography checks whether the fallopian tubes are open by tracking contrast dye as it fills the uterus and spills out the tubes. But the most important safety check before this test has nothing to do with the tubes at all. The dye travels from the cervix into the uterus and out through the tubes. Free spill means the tubes are patterned and open, while dye that stops short signals a blockage. The contrast is iodine-based, and a person allergic to iodine or shellfish can react to it, even to the point of anaphylaxis. That's why the nurse screens for these allergies before the test proceeds, catching a dangerous exposure before it happens. Timing matters as well. The test is scheduled after menstrual bleeding ends, but before ovulation, avoiding a possible early pregnancy and reducing the risk of pushing bacteria upward. Mild brief cramping during the dye injection is expected. Students often focus on fasting or bladder emptying, but the iodinated contrast is what makes allergy screening the top priority, just as it is before any contrast-based imaging study. Question 15. A nurse is caring for a client starting medication to stimulate ovulation for infertility. Which information should the nurse include in teaching? Your options are A. It prevents future miscarriage, B. It guarantees a single pregnancy, C. It lowers the chance of twins, D. It raises the chance of multiples. Don't overthink it. Which one feels right? The correct answer is D. It raises the chance of multiples. D is correct because ovulation-stimulating medications can cause more than one follicle to mature, which noticeably increases the chance of a multiple pregnancy, so the client should be prepared for that possibility. A is wrong because these medications promote ovulation and do not protect an established pregnancy from miscarriage. B is wrong because no fertility medication guarantees pregnancy, and stimulating ovulation actually makes a multiple pregnancy more, not less, likely. C is wrong because the medication increases the likelihood of twins or higher order multiples rather than reducing it. Fertility medications help the ovaries mature and release an egg in women who aren't ovulating reliably. Oral drugs like clomiphene and letrozole act on the brain, while injectable gonadotropins act directly on the ovaries. The key teaching point is this: because these drugs push the ovaries harder, they can mature more than one follicle in a single cycle. That means twins, and less often triplets or higher order multiples, happen more often than with unassisted conception. A second risk to know is ovarian hyperstimulation syndrome, especially with injectable gonadotropins, where the ovaries swell and fluid shifts out of the bloodstream. Warning signs include rapid weight gain, abdominal bloating and pain, and shortness of breath, and providers monitor with ultrasound and hormone levels to keep stimulation safe. The nuance these questions test is that fertility drugs don't just improve the odds of one healthy pregnancy. Recruiting multiple follicles is the very mechanism that raises the chance of more than one baby at a time, and that trade-off must be named honestly. When a question tests teaching about ovulation-inducing drugs, the correct answer names the increased chance of multiples as the key counseling point. Question 16. A nurse is supporting a couple who just learned they are experiencing infertility. Which nursing action is most appropriate? Your options are: I will encourage them to express their feelings. B. Reassure them it will resolve. C. Suggest they adopt instead. D. Tell them to relax and wait. Got a guess? Lock it in. The correct answer is A. Encourage them to express their feelings. A is correct because infertility is a significant life stressor that brings grief and strain. So allowing the couple to talk openly about their feelings supports coping and guides further care. B is wrong because false reassurance dismisses the couple's distress and promises an outcome the nurse cannot guarantee. C is wrong because steering the couple toward adoption ignores their current feelings and removes their right to weigh options themselves. D is wrong because telling the couple to simply relax minimizes a real medical concern and offers no genuine support. Infertility is more than a diagnosis. It's a loss, often grieved like the death of an imagined future, and good nursing care begins by recognizing that emotional weight. A couple newly facing infertility mourns a pregnancy that hasn't come and a sense of control that slipped away, cycling monthly between hope and disappointment. That grief has to be acknowledged before anything else can be absorbed. The nurse's real skill here is active, attentive listening paired with acknowledgement, naming the difficulty, allowing silence, and validating that guilt, anger, and shame are normal. This is what helps a couple feel truly heard. What the nurse avoids matters just as much. False reassurance, like telling a couple to simply relax, minimizes a real medical problem and implies blame. Empty optimism and unsolicited advice close down communication rather than open it. Assessment, education, and referral all matter. But when the emotional wound is fresh, supporting the couple's feelings always comes first. Question 17. A nurse is reviewing early indicators of pregnancy with a client. Which finding is considered a positive sign of pregnancy? Your options are: A. Nausea in the morning. B. A positive home pregnancy test. C. Fetal heartbeat heard by the examiner. D. A missed menstrual period. Which one is it? Pause the video if you need more time. The correct answer is C. Fetal heartbeat heard by the examiner. C is correct because positive signs can be explained only by pregnancy, and an examiner hearing the fetal heartbeat is one of those confirmed findings, unlike signs that other conditions can mimic. A is wrong because nausea is a presumptive sign reported by the client and can arise from many non-pregnancy causes. B is wrong because a pregnancy test detects a hormone and is a probable sign, since certain conditions can produce a similar result. D is wrong because a missed period is a presumptive sign the client notices, and stress or illness can also cause it. Signs of pregnancy fall into 3 tiers of certainty: presumptive, probable, and positive. They climb from weakest to strongest proof, and only the top tier is truly conclusive. Presumptive signs are what the woman herself feels, like a missed period, nausea, or fatigue, and each has other possible causes. Probable signs are objective findings an examiner can observe, like a positive test or Chadwick sign, but they can still occasionally be mimicked by something else. Positive signs are the only findings that require an actual fetus to exist: a heartbeat detected by an examiner, fetal movement felt by an examiner, and direct visualization on ultrasound. None of these can be faked by hormones, tumors, or perception. Picture a nurse assessing a woman who reports nausea and a missed period, then a positive test and bluish cervix. When the Doppler picks up a fetal heartbeat, that examiner-detected sound settles what the earlier findings could only suggest. The distinguishing rule is causation. Presumptive signs are felt by the woman. Probable signs are seen by an examiner but can be mimicked. And positive signs can only be caused by a real fetus. Question 18. A nurse is examining a client suspected of being pregnant and notes a bluish-purple color of the cervix and vaginal wall. Which sign should the nurse document? Your options are A. Quickening, B. Chadwick sign, C. Hagar sign, D. Ballottement. Take a second. Which answer would you pick? The correct answer is B. Chadwick sign. B is correct because the deepened bluish violet color of the cervix and vaginal mucosa from increased blood flow is the Chadwick sign, a probable indicator the examiner observes during pregnancy. A is wrong because quickening describes the first fluttering fetal movements the client feels, not a color change seen on examination. C is wrong because the Hagar sign is softening of the lower uterine segment, which is felt rather than seen as discoloration. D is wrong because ballottement is the rebound of the fetus when the examiner taps the cervix, not a change in tissue color. Chadwick sign is a bluish-purple discoloration of the cervix, vaginal walls, and vulva seen in early pregnancy. It's a probable sign of pregnancy, visible to an examiner, but not enough on its own to confirm it. Rising estrogen makes pelvic blood vessels dilate and fill, so more blood moves through the region. That engorgement shows through the thin cervical and vaginal tissue as a dusky bluish-purple hue, the same way any tissue packed with slow, oxygen-poor blood looks bluish. Chadwick sign travels with 2 other classic findings. Goodell sign is softening of the cervix itself, and Hagar sign is softening of the isthmus, the lower part of the uterus just above the cervix. Students often mix these 3 up. Chadwick is the color change, Goodell is softening of the cervix, and Hagar is softening of the lower uterine segment. Matching the description to the right name is the key skill. All 3 signs stem from the same hormone-driven surge in blood flow, but none of them confirm pregnancy on their own. They simply raise the probability. Question 19. A nurse is teaching a client in the supine position who suddenly feels dizzy, pale, and clammy late in pregnancy. Which action should the nurse take? Your options are A. Have the client sit upright, B. Give oxygen by face mask, C. Raise the head of the bed, D. Turn the client onto her side. Before I reveal it, which one do you think is right? The correct answer is D. Turn the client onto her side. D is correct because these findings suggest the heavy uterus is compressing the major vessel and reducing blood return. So turning the client to her side relieves the pressure and restores circulation. A is wrong because sitting upright fails to shift the uterus away from the vessel and may not relieve the dizziness quickly. B is wrong because oxygen does not address the underlying cause, which is mechanical pressure that sideline relieves directly. C is wrong because raising the head does not move the uterus off the compressed vessel, so the low blood pressure would continue. Late in pregnancy, the position a woman lies in can dramatically change her blood pressure. This is supine hypotensive syndrome, and understanding the mechanism makes the correct response obvious. When a woman near term lies flat on her back, the heavy uterus presses down on the inferior vena cava, the vein carrying blood from the lower body back to the heart. Compressing that vein throttles blood return, and the effects ripple upward through the whole circulation. Less blood returning to the heart means less blood pumped out, so cardiac output and blood pressure fall. The woman feels dizzy, lightheaded, nauseated, pale, and clammy, and reduced flow to the uterus and placenta can stress the fetus too. Turning the woman onto her side, classically the left side, rolls the uterus off the vena cava and restores blood flow to the heart. Cardiac output and blood pressure recover almost immediately, and even a hip wedge can be enough. When flat positioning, late pregnancy, and dizziness, pallor, or clamminess appear together, think supine hypotensive syndrome. The fix is mechanical. Move the uterus off the vena cava by turning her onto her side before reaching for anything else. Question 20. A nurse is teaching a client at her first prenatal visit about expected skin changes during pregnancy. Which finding should the nurse describe as normal? Your options are A. A dark line down the abdomen, B. Pale, cool skin, C. Yellowing of the skin, D. Widespread bruising. What's your answer? Commit to one before I continue. The correct answer is A. A dark line down the abdomen. A is correct because hormone changes cause a darkened line down the midline of the abdomen called the linea nigra, which is an expected and harmless change of pregnancy. B is wrong because pale, cool skin suggests poor circulation rather than the increased pigmentation typical of pregnancy. C is wrong because yellow-tinged skin can point to a liver problem and is not a normal change to expect during pregnancy. D is wrong because widespread bruising may signal a clotting concern and is not an ordinary skin finding in pregnancy. During pregnancy, a dark line often appears down the middle of the belly. This is the linea nigra, and it's a completely normal expected change, not a warning sign. That midline path is actually there before pregnancy, as a fat band of connective tissue. Rising hormones simply darken it until it stands out against the skin. The cause is hormonal. Estrogen and progesterone stimulate the skin's pigment-producing cells to make extra melanin. That melanin concentrates in classic spots: the abdominal midline, the areola, and sometimes the face. The linea nigra keeps company with other normal changes: chloasma, the blotchy facial darkening, darker areolae, and stria gravidarum, or stretch marks, which come from stretching rather than pigment. All are benign and typically fade after birth. When a question describes a dark line down the abdomen as an expected skin change, it's pointing to the linea nigra, a harmless result of pregnancy hormones. Question 21. A nurse is teaching a pregnant client who reports frequent heartburn, especially after large meals and when lying down. Which instruction should the nurse include to help relieve it? Your options are A. Drink large amounts with meals, B. Eat small frequent meals, C. Lie down right after eating, D. Increase fried foods. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Eat small frequent meals. B is correct because small Frequent meals keep the stomach from becoming overly full and reduce the reflux that causes heartburn as the growing uterus presses upward on the stomach. A is wrong because large amounts of fluid with meals add to stomach fullness and can make reflux more likely. C is wrong because lying down soon after eating lets stomach contents flow back upward, which worsens heartburn rather than easing it. D is wrong because fried and fatty foods slow stomach emptying and tend to trigger heartburn, so they should be limited. Heartburn in later pregnancy comes down to two forces working together, and understanding them tells you exactly how to relieve it. Progesterone relaxes the ring of muscle that normally seals the stomach, letting acid slip backward into the esophagus. At the same time, the growing uterus crowds the stomach from below, raising the pressure inside and pushing acid upward. Think of the stomach like a balloon that's already being squeezed by the growing uterus. Add a large meal, and the extra volume pushes even harder against that weakened valve, forcing acid upward, especially when lying flat removes gravity's help. Relief centers on controlling volume and position. Small, frequent meals prevent overfilling the stomach. Staying upright after eating lets gravity keep acid down. Avoiding fatty or spicy foods reduces irritation, and raising the head of the bed keeps acid where it belongs overnight. Every effective strategy targets one of two things: how much is in the stomach, or which direction acid can travel. Master that logic and pregnancy heartburn questions become easy to solve. Question 22. A nurse is reviewing the prenatal visit schedule with a client who has an uncomplicated pregnancy at 30 weeks of gestation. How often should the nurse explain visits will occur now? Your options are: A. Only if problems arise. B. Once a month. C. Every 2 weeks. D. Every week. Which would you go with? Lock it in before the reveal. The correct answer is C. Every 2 weeks. C is correct because during an uncomplicated pregnancy, visits move to every 2 weeks from about 29 through 36 weeks, so the provider can monitor the client and fetus more closely as term nears. M is wrong because routine visits continue on a set schedule to catch problems early, not only when symptoms appear. B is wrong because monthly visits apply to the earlier weeks. By this point, the schedule increases to every 2 weeks. D is wrong because weekly visits begin around 36 weeks, which is later than the client's current point in pregnancy. Prenatal visits aren't spaced evenly across pregnancy. The schedule tightens as the due date nears because that's when risk to mother and baby rises fastest. For an uncomplicated pregnancy, there are 3 phases. From the first visit to 28 weeks, visits happen monthly. From 28 to 36 weeks, every 2 weeks. From 36 weeks until birth, weekly. The conditions most dangerous to mother and baby tend to develop later in pregnancy: gestational hypertension and preeclampsia, gestational diabetes, fetal growth problems, and changes in fetal well-being. More frequent visits catch these early, while there's still time to act. Each visit includes the same core checks: blood pressure, urine screening, fundal height measurement, and fetal heart rate and movement. As visits become more frequent, these checks happen more often too, improving the odds of catching a problem early. So a client at 30 weeks falls squarely in the middle phase, seen every 2 weeks until 36, then weekly until delivery. The gestational age in the question is the clue that pins down the correct interval. Question 23. A nurse is reviewing initial prenatal laboratory results for a client who is Rh negative and not sensitized. Which intervention should the nurse anticipate? Your options are: A. Arch immune globulin at 28 weeks. B. Weekly ultrasounds. C. Daily iron infusions. D. Strict bed rest. Don't overthink it. Which one feels right? The correct answer is A. Rate immune globulin at 28 weeks. A is correct because an Rh negative client who is not sensitized receives Rh immune globulin around 28 weeks to prevent her body from forming antibodies against Rh positive fetal blood. B is wrong because being Rh negative alone does not require weekly ultrasounds, which are reserved for specific fetal concerns. C is wrong because Rh status does not call for iron infusions. That treatment addresses anemia rather than blood type incompatibility. D is wrong because Rh status does not warrant bed rest, which is used for conditions such as preterm labor or bleeding. Immune globulin is a preventive treatment that stops a dangerous immune problem before it ever begins. Understanding the underlying incompatibility is the key to knowing when it's given. If a negative mother is exposed to her R-positive fetus's red blood cells, most often during birth, her immune system can recognize them as foreign and start making antibodies. Once she's sensitized, those antibodies last for life and can attack red cells in a future Rh-positive pregnancy, causing hemolytic disease. Immune globulin works by coating any fetal Rh-positive cells that reach the mother's blood, clearing them before her immune system can respond. It's given prophylactically around 28 weeks, and again within 72 hours after birth if the newborn is Rh-positive, at a standard dose of about 300 micrograms. The critical nuance is that this treatment only works before sensitization occurs. Once antibodies exist, immune globulin cannot undo them. So a stem describing an Rh negative, not sensitized woman with a negative antibody screen at 28 weeks is signaling that Rh immune globulin prophylaxis is the anticipated action. Recognizing the not sensitized status is what these questions reward, distinguishing prophylaxis from treatment of an already sensitized woman or the current fetus. Question 24. A nurse is performing Leopold maneuvers on a pregnant client. Which action should the nurse take before beginning? Your options are A. Offer the client a large meal. B. Have the client empty her bladder. C. Place the client flat on her back. D. Position the client standing. Got a guess? Lock it in. The correct answer is B. Have the client empty her bladder. B is correct because asking the client to empty her bladder first improves comfort and makes it easier to palpate the fetal position, since a full bladder can interfere with the examination. A is wrong because a large meal does not aid palpation and may add to the client's discomfort during the examination. C is wrong because lying completely flat can compress the major vessel. A small wedge under one hip is used to prevent low blood pressure. D is wrong because Leopold maneuvers are performed with the client lying down, not standing, so the abdomen can be palpated. Leopold maneuvers are 4 systematic palpations a nurse uses to determine fetal position, including what's at the top of the uterus, which side the back is on, what presents at the pelvic inlets, and how far the fetus has descended. But before any of that palpation can be accurate, one preparation step matters most. Since Leopold maneuvers rely on feeling fetal parts through the abdominal wall, a full bladder gets in the way. It sits low, distorts the contour, causes discomfort, and obscures the very structures the examiner needs to feel. So emptying it first improves both comfort and reliability. Positioning supports the same goal. The woman lies back with knees slightly bent to relax abdominal muscles, and a small wedge prevents dizziness from uterine pressure on the vena cava. Warm, gentle hands keep her relaxed. Since a cold or abrupt touch causes guarding that tightens the muscles the examiner needs to feel through. Picture the nurse asking the woman to empty her bladder, then helping her lie back with knees bent before laying hands on the abdomen. With the bladder empty and muscles loose, fetal parts become far easier to distinguish. Don't confuse this with procedures like early ultrasound, which actually require a full bladder. Palpation needs an unobstructed, comfortable abdomen, so emptying the bladder first is the logical, sound action before beginning. Question 25. A nurse is teaching a client at 8 weeks of gestation about warning signs to report during the first trimester. Which findings should the nurse instruct the client to report immediately? Your options are A. Occasional fatigue, B. Mild breast tenderness, C. Vaginal bleeding with cramping, D. Nausea in the morning. Which one is it? Pause the video if you need more time. The correct answer is C. Vaginal bleeding with cramping. C is correct because vaginal bleeding with cramping in early pregnancy can signal miscarriage or an ectopic pregnancy, so the client should report it right away for prompt evaluation. A is wrong because fatigue is a common and harmless first trimester complaint rather than a danger sign. B is wrong because breast tenderness is an expected early change from rising hormones and does not require urgent reporting. D is wrong because morning nausea is typical in early pregnancy and is concerning only if it becomes severe and persistent. In the first trimester, one combination stands above all others as an urgent warning sign: vaginal bleeding together with cramping. This pairing raises concern for miscarriage or for an ectopic pregnancy. So nurses teach women to report it immediately rather than wait to see if it passes. Light spotting by itself can be harmless, but when cramping joins the bleeding, it signals something more serious. In a miscarriage, cramping shows the uterus working to expel its contents. In an ectopic pregnancy, it can mean a growing embryo is stretching or rupturing a fallopian tube, which can become a surgical emergency. An ectopic pregnancy happens when the embryo implants outside the uterus, most often in a fallopian tube, a space that cannot safely expand to support a growing pregnancy. Nausea, breast tenderness, and fatigue are expected first trimester discomforts and not alarming. Bleeding with cramping is different in kind because it can mean a possible loss or a misplaced pregnancy, and that distinction is exactly what these questions test. Timing changes outcomes, since an ectopic pregnancy caught early can be treated before a tube ruptures. So whenever a STEM describes vaginal bleeding with cramping in the first trimester, the answer is always the same: call the provider right away. Question 26. A nurse is caring for a client who reports decreased fetal movement in the third trimester. Which instruction about kick count should the nurse provide? Your options are A. Stop counting after one movement, B. Count only when the baby is active, C. Count once a week is enough, D. Report fewer than expected movements. Take a second. Which answer would you pick? The correct answer is D. Report fewer than expected movements. D is correct because a clear drop in fetal movement can indicate the fetus is not tolerating the pregnancy well, so the client should report counts that fall below the expected number. A is wrong because the client tracks movements over a set period instead of stopping after a single kick, which would give no useful information. B is wrong because the client counts at set times after meals or rest, not only when she happens to feel activity, so a true pattern emerges. C is wrong because kick counts are done daily, often 2 to 3 times a day, rather than once a week. Fetal movement is a window into how the baby is doing, and kick counts turn that window into something a woman can monitor at home during the third trimester. A common approach has the woman rest quietly after a meal, when the fetus tends to be active, lie on her side, and count movements, expecting around 10 within about 2 hours. The mechanism behind the concern is placental function. The placenta delivers oxygen and nutrients, and when it begins to fail, the fetus conserves energy by moving less. The key nuance is that increased movement is reassuring, while decreased movement is the red flag, because a stressed, oxygen-deprived fetus conserves energy by moving less, and that decline should be reported right away. So the sound teaching is simple. A quiet fetus can be an early warning sign, and a woman should report fewer movements than expected, so her provider can act before it becomes an emergency. Question 27. A nurse is teaching a client in the first trimester about recommended weight gain for a healthy single pregnancy at a normal weight. Which range should the nurse describe? Your options are A. About 40 to 50 pounds. B. About 25 to 35 pounds. C. About 15 to 20 pounds. D. About 5 to 10 pounds. Before I reveal it, which one do you think is right? The correct answer is B. About 25 to 35 pounds. B is correct because a client at a normal pre-pregnancy weight is guided toward gaining roughly 25 to 35 pounds over the pregnancy to support healthy fetal growth without excess. A is wrong because 40 to 50 pounds is excessive and increases the risk of a large infant and birth complications. C is wrong because 15 to 20 pounds is the target for a client who begins pregnancy overweight, not at a normal weight. D is wrong because 5 to 10 pounds is far too little and raises the risk of a low birth weight, newborn. Pregnancy weight gain isn't one fixed number. It's a range tuned to where a woman starts. And for a normal weight woman carrying one baby, that range is about 25 to 35 pounds. The recommendation shifts with the mother's starting body size. Underweight women are advised to gain 28 to 40 pounds. Normal weight women 25 to 35. Overweight women 15 to 25. And women with obesity 11 to 20 pounds. That weight isn't just the baby. It includes the placenta, amniotic fluid, expanded blood volume, breast tissue, uterus growth, and the mother's own energy stores, all supporting a healthy pregnancy. The gain also follows a timing pattern. The first trimester adds very little since the fetus is still tiny, while most of the gain happens in the second and third trimesters, at roughly a pound a week for a normal weight woman. The key is anchoring 25 to 35 pounds specifically to a normal weight woman with one fetus. Twins or a different starting weight change the target. So the details in the question always determine the right range. Question 28. A nurse is counseling a client who wishes to become pregnant about preventing neural tube defects. Which nutrient should the nurse emphasize? Your options are vitamin C, B, calcium, C, vitamin D, D, folic acid. What's your answer? Commit to one before I continue. The correct answer is D, folic acid. D is correct because folic acid is essential for early neurologic development. An adequate intake before and during pregnancy lowers the risk of neural tube defects in the developing fetus. Is wrong because vitamin C supports iron absorption and tissue health, but does not prevent neural tube defects. B is wrong because calcium builds bones and teeth, yet it has no specific role in preventing neural tube defects. C is wrong because vitamin D aids calcium use and bone health, but is not the nutrient that guards against neural tube defects. Folic acid's most important job is preventing neural tube defects, but the real key to this concept is timing. The neural tube is the embryonic structure that folds and closes to become the brain and spinal cord. Folic acid fuels the rapid cell division needed to seal it, but if it fails to close, the result can be spina bifida or anencephaly. The neural tube closes by about 28 days after conception, often before a woman even knows she's pregnant. If she waits for a positive test to start folic acid, the critical window may already have passed, and once the tube has closed, supplementation cannot undo the damage. Most women capable of pregnancy should take about 400 micrograms daily. Women trying to conceive often take 400 to 600 micrograms, and those with a prior neural tube defect pregnancy need a much higher dose under provider guidance. The lesson these questions test is preconception timing. Emphasize folic acid for women planning pregnancy, because the neural tube forms and closes before they may even know they've conceived. Question 29. A nurse is teaching a pregnant client who has iron deficiency anemia about taking her iron supplement. Which instruction should the nurse include? Your options are: I take it with orange juice. B. Take it with milk. C. Take it with an antacid. D. Take it with coffee. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Take it with orange juice. A is correct because vitamin C improves iron absorption. So taking the supplement with orange juice helps the body use the iron and supports correction of the anemia. B is wrong because milk contains calcium, which interferes with iron absorption and reduces the supplement's benefit. C is wrong because antacids lower stomach acidity and decrease iron absorption, working against the goal of treating the anemia. D is wrong because the caffeine in coffee blocks iron absorption, so it should not be taken together with the supplement. Pregnancy increases the risk of iron deficiency anemia because blood volume expands faster than red cell mass, and the fetus draws on maternal iron stores. But once iron is prescribed, how it's taken matters just as much as taking it. Iron is absorbed best in its ferrous form, and vitamin C helps keep it that way while enhancing uptake in the intestine. An acidic environment favors this process, which is why iron is often paired with orange juice or taken on an empty stomach. Vitamin C and an empty stomach boost absorption, while calcium from milk or supplements, and tannins in tea and coffee, block it. That is the core distinction these questions test. Nurses also prepare women for iron side effects, since it commonly causes constipation and darkens the stool. Teaching includes fluids and fiber, along with reassurance that these changes are expected and not dangerous. The small adjustment of pairing iron with orange juice and keeping it apart from milk turns a prescription into one that actually works. Question 30. A nurse is reviewing the diet history of a pregnant client who reports craving and eating laundry starch and clay. Which condition should the nurse recognize? Your options are: A. Tialism, B. Hyperemesis, C. Pica, D. Heartburn. Which would you go with? Lock it in before the reveal. The correct answer is C. Pica. C is correct because craving and eating non-food substances such as starch or clay is called pica, which can crowd out nutritious foods and contribute to deficiencies during pregnancy. A is wrong because tialism is excessive saliva production, which differs entirely from the pattern of pica. B is wrong because hyperemesis refers to severe, persistent vomiting, not the craving and intake of non-food items. D is wrong because heartburn is a burning chest discomfort from reflux and is unrelated to eating non-food substances. Pica is the persistent craving and eating of non-food substances, and recognizing this pattern by name is exactly what these questions test. In pregnancy, pica shows up as urges to eat laundry starch, clay or dirt, ice in large amounts, chalk, or ashes. The key is a recurring pattern of eating non-food items, not just an unusual taste now and then. Pica is closely linked to iron deficiency anemia, though the exact cause isn't fully settled. Low iron may disrupt appetite regulation and drive the cravings. while substances like clay and starch bind minerals in the gut, worsening the very deficiency that may have started it. The risks make pica more than a curiosity. Filling up on starch or clay can displace nutritious food, and some substances introduce toxins, lead, or parasites, or even cause intestinal blockage. That's why identifying pica opens the door to checking iron levels and offering shame-free nutritional counseling. When a diet history reveals a pregnant woman eating laundry, starch, and clay, the nurse's job is simply to recognize the pattern as pica, which then opens the path to checking for anemia and nutritional risk. Question 31. A nurse is preparing a client for an abdominal ultrasound early in pregnancy. Which instruction should the nurse provide before the procedure? Your options are A. Empty the bladder completely. B. Take a laxative beforehand. C. Remain fasting overnight. D. Drink fluids to fill the bladder. Don't overthink it. Which one feels right? The correct answer is D. Drink fluids to fill the bladder. D is correct because a full bladder lifts the uterus and improves the image during an abdominal ultrasound. So the client is asked to drink fluids and not void before the scan. A is wrong because emptying the bladder would lower the uterus and worsen the image quality the full bladder helps provide. B is wrong because a laxative serves no purpose for an ultrasound and is unrelated to obtaining a clear image. C is wrong because fasting is not required for an ultrasound, which does not involve sedation or contrast affected by food. Why does an early abdominal ultrasound require a full bladder? The answer comes down to physics and anatomy working together. In early pregnancy, the uterus sits low behind the pubic bone, surrounded by gas-filled bowel. Ultrasound travels poorly through gas and bone, so without help the image would be murky and obstructed. A full bladder solves this two ways. It pushes the bowel out of the beam's path, and it lifts the uterus upward into better range. Because fluid conduct sounds so cleanly, the bladder becomes a clear acoustic window for the ultrasound beam. This rule is specific to early transabdominal scans. Later in pregnancy, the amniotic fluid itself provides the window, and transvaginal scans place the probe close enough that a full bladder isn't needed. Procedures like amniocentesis, by contrast, call for an empty bladder. The key is matching bladder preparation to the timing and type of ultrasound, not applying one rule to every scan. Question 32. A nurse is reviewing the results of a non-stress test that is documented as reactive. How should the nurse interpret this finding? Your options are A. It is a reassuring result. B. The fetus is in distress. C. Labor should be induced. D. A cesarean is needed. Got a guess? Lock it in. The correct answer is A. It is a reassuring result. A is correct because a reactive non-stress test shows the fetal heart rate accelerating appropriately with movement, which is a reassuring sign of fetal well-being and an intact nervous system. B is wrong because a reactive result is normal and indicates the fetus is doing well, not that it is in distress. C is wrong because a reassuring test points to fetal well-being and does not signal a need to induce labor. D is wrong because a reactive result supports continuing the pregnancy and does not indicate that a cesarean is required. The non-stress test checks fetal well-being by watching how the fetal heart rate responds to the baby's own movements, using sensors on the mother's abdomen over about 20 minutes. The underlying idea is simple. A fetus that is well oxygenated and neurologically healthy will show brief speed-ups in heart rate whenever it moves, just like a healthy person's pulse rises with activity. A reactive result is the reassuring finding. The heart rate accelerates appropriately with movement. At least 2 accelerations rise in about 15 beats per minute above baseline, and lasting 15 seconds each within the 20-minute window. Reactive means accelerations are present and signal an intact nervous system and good oxygenation. Non-reactive simply means those accelerations didn't appear, which isn't automatically bad news, but calls for further evaluation like extended monitoring, fetal stimulation, or a contraction stress test. The nuance these questions test is reading reactive correctly as good news, not alarming. Reactive equals reassuring is the anchor to hold on to. Question 33. A nurse is reviewing a contraction stress test that shows late decelerations with most contractions. How should the nurse interpret this result? Your options are negative and reassuring, B, positive and abnormal, C, expected for this test, D, normal variation. Which one is it? Pause the video if you need more time. The correct answer is B, positive and abnormal. B is correct because repeated late decelerations with contractions make the contraction stress test positive, suggesting the placenta may not support the fetus well during the stress of labor. A is wrong because a negative result shows no late decelerations. The presence of late decelerations is the opposite, an abnormal finding. C is wrong because late decelerations are not an expected or desired response and signal a problem with placental function. D is wrong because late decelerations are not a normal variation. They indicate the fetus may not tolerate labor. The contraction stress test checks whether a fetus can handle the reduced blood flow that happens during uterine contractions, and its scoring hides a twist that trips up learners. A late deceleration is a smooth dip in fetal heart rate that starts only after the contraction has peaked and recovers after the contraction ends. That delay is the fingerprint of uteroplacental insufficiency, meaning the placenta cannot deliver enough oxygen during the stress of a contraction. Here is the twist. A test showing late decelerations with most contractions is called positive, and positive is the abnormal, worrisome result. A negative test with no late decelerations is the reassuring, normal outcome, even though everyday language suggests the opposite. Think of it like a warning light mislabeled positive for trouble instead of good news. Holding that chain firmly, positive equals late decelerations equals a fetus struggling equals abnormal, is what makes the interpretation reliable. Whenever a stem describes late decelerations with most contractions, read that as positive and abnormal, not as good news. Question 34. A nurse is caring for a client scheduled for an amniocentesis at 16 weeks of gestation. Which action should the nurse take before the procedure? Your options are A, position the client prone, B, give a full liquid meal, C, ask the client to empty her bladder, D, withhold all fluids. Take a second. Which answer would you pick? The correct answer is C. Ask the client to empty her bladder. C is correct because at this stage the client empties her bladder before the amniocentesis, so the bladder is not punctured, since the lower bladder could otherwise be in the needle's path. A is wrong because the client lies on her back with a wedge under one hip, not prone, so the abdomen is accessible and circulation is protected. B is wrong because a liquid meal is unnecessary and does not improve the safety or accuracy of the procedure. D is wrong because withholding all fluids is not required, and the key preparation is emptying the bladder rather than restricting intake. Amniocentesis at 16 weeks involves passing a thin needle through the abdominal wall to sample amniotic fluid, guided the whole time by ultrasound. But the key prep step that trips learners up isn't about the needle itself, it's about the bladder. By 16 weeks, the uterus has grown up out of the pelvis and become an abdominal organ. Ultrasound shows the fetus, the placenta, and the fluid pocket, letting the provider steer the needle safely toward the fluid while an empty bladder sits low and clear of the needle's path. This is the exact opposite of the rule for early abdominal ultrasound, where a full bladder lifts the low-lying uterus into view. Once the uterus has risen on its own by the second trimester, that full bladder no longer helps. It becomes a hazard directly in the needle's path. A learner who overgeneralizes the full bladder rule from early ultrasound would prepare the woman incorrectly and raise her risk of an accidental bladder puncture. The reasoning is purely anatomical. Once the uterus is an abdominal organ, emptying the bladder keeps it out of the needle's way. Signal phrases to remember are amniocentesis, 16 weeks, and empty the bladder. Matching bladder preparation to the specific procedure and gestational age is exactly what these questions reward. Question 35. A nurse is reviewing an elevated maternal serum alpha-fetoprotein result with a client. Which condition does this finding most suggest? Your options are A. Gestational diabetes, B. A neural tube defect, C. Down syndrome, D. A molar pregnancy. Before I reveal it, which one do you think is right? The correct answer is B. A neural tube defect. B is correct because a high maternal serum alpha-fetoprotein level is associated with neural tube defects such as spina bifida. So an elevated result prompts further evaluation of the fetus. A is wrong because gestational diabetes is detected through glucose testing and is unrelated to the alpha-fetoprotein level. C is wrong because Down syndrome is linked with a low alpha-fetoprotein level, not an elevated one. D is wrong because a molar pregnancy is identified mainly by very high pregnancy hormone levels and ultrasound, not a high alpha-fat protein. Maternal serum alpha-fetoprotein is a second trimester blood test that screens for certain fetal conditions by measuring a protein made by the fetus. It's only a screen, not a diagnosis, but the direction of an abnormal result carries real meaning. AFP is normally made by the fetal liver and yolk sac, with small amounts crossing into the mother's blood. But when the neural tube fails to close, as in spina bifida or anencephaly, the open lesion lets extra protein leak into the amniotic fluid and then the maternal bloodstream, producing an elevated reading. Elevated levels raise concern for open neural tube defects, abdominal wall defects, multiple pregnancies, or a pregnancy further along than dates suggest. A low level, by contrast, is linked to chromosomal conditions like Down syndrome, and dating errors must always be ruled out first. Picture a nurse explaining an elevated result. The high level raises concern for a neural tube defect, so the provider orders a detailed ultrasound and possibly amniocentesis. The elevated protein is only a flag for follow-up, never a final answer. High means an opening leaking protein, most classically a neural tube defect. Low points toward chromosomal problems. Either way, an abnormal AFP sorts pregnancies into risk categories and calls for further testing, not a conclusion. Question 36. A nurse is teaching a pregnant client about caffeine intake. Which client statement indicates a need for further teaching? Your options are: water is a better daily choice. B. I will limit my caffeine intake. C. Too much caffeine may harm pregnancy. D. I can drink unlimited coffee daily. What's your answer? Commit to one before I continue. The correct answer is D. I can drink unlimited coffee daily. D is correct because excess caffeine is linked with pregnancy risks, so intake should be limited. Believing it can be consumed freely shows the client needs further teaching. A is wrong because choosing water over caffeinated drinks is appropriate and shows the client grasps the teaching. B is wrong because keeping caffeine to a moderate limit reflects accurate understanding rather than a misconception to correct. C is wrong because recognizing that high caffeine intake can harm the pregnancy is a correct statement, not an error. Caffeine crosses the placenta freely, and because a fetus can't break it down like an adult can, the guidance isn't never, it's moderation. High intake has been linked to risks, like miscarriage and low birth weight, which is why a modest daily cap matters. The commonly cited ceiling is about 200 milligrams a day, roughly 1 12-ounce cup of coffee. But the teaching isn't forbidden. It's counted and capped, including hidden caffeine in tea, soda, energy drinks, chocolate, and some medications. Caffeine passes through the placenta into fetal circulation at levels similar to the mother's. But the fetal liver is immature, so caffeine lingers much longer in the baby than it would in an adult. A woman who drinks just 1 cup of coffee but adds several sodas and some chocolate can exceed the limit without realizing it. That's why the teaching is to tally every source, not just coffee. When a question asks which statement needs further teaching, the claim that a woman can drink unlimited coffee is the red flag. The correct understanding is a modest, counted daily cap of about 200 milligrams, not total prohibition and not free reign. Question 37. A nurse is teaching a pregnant client who follows a strict vegetarian diet. Which nutrient should the nurse emphasize may need supplementation? Your options are A. Vitamin B12, B. Sodium, C. Potassium, D. Vitamin A. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Vitamin B12. A is correct because vitamin B12 is found mainly in animal products. So a client on a strict vegetarian diet may need a supplement to meet the increased needs of pregnancy. B is wrong because sodium is plentiful in most diets and is not a nutrient that a vegetarian pregnant client typically lacks. C is wrong because potassium is abundant in fruits and vegetables, making a deficiency unlikely on a vegetarian diet. D is wrong because vitamin A is available from many plant foods, so deficiency is not the main concern with a vegetarian diet. A strict vegetarian or vegan diet can meet nearly all of pregnancy's nutritional needs with careful planning, but one nutrient stands out as genuinely hard to get: vitamin B12. Vitamin B12 comes almost exclusively from meat, fish, eggs, and dairy. It's essential for making healthy red blood cells and for building the nervous system. And during pregnancy, the fetus relies entirely on the mother's supply for its own developing blood and nerve tissue. Because the body stores B12 and depletes it slowly, a shortfall can go unnoticed until it affects the mother's blood cells or the baby's developing nervous system, which is why proactive supplementation is safer than waiting for symptoms. The practical solution is supplementation or fortified foods like plant milks, cereals, and nutritional yeast. The nurse's job is to identify the dietary pattern, flag B12 as the nutrient at risk, and make sure the woman has a dependable source. Iron, protein, and calcium can usually be found in plants, but B12 is uniquely tied to animal foods, making it the standout nutrient to flag for a strict vegetarian in pregnancy. Question 38. A nurse is caring for a client who has a positive pregnancy test and reports a previous pregnancy that ended at 10 weeks. Which information is most important for the nurse to obtain? Your options are A. Preferred room temperature, B. Favorite foods, C. A complete obstetric history, D. Exercise brand preferences. Which would you go with? Lock it in before the reveal. The correct answer is C. A complete obstetric history. C is correct because a complete obstetric history reveals past losses, complications, and outcomes that shape current risk and guide the plan of care for this pregnancy. A is wrong because room temperature preference has no bearing on assessing the client's reproductive history or current risk. B is wrong because food preferences, while useful for later diet teaching, are not the priority when establishing pregnancy risk. D is wrong because exercise brand preferences are irrelevant to the obstetric history the nurse needs to gather first. When a woman arrives newly pregnant with a history of an earlier pregnancy, gathering a complete obstetric history is one of the most important early steps a nurse can take. A single detail, like knowing a pregnancy ended at 10 weeks, is far less useful than the full story. Past events such as miscarriage, preterm birth, cesarean delivery, or preeclampsia each raise specific risks and change how closely this pregnancy is watched. Nurses capture this using gravida, the total number of pregnancies, and para, the number reaching viability, further broken into term births, preterm births, miscarriages, and living children. A 10-week loss becomes one data point within this complete organized summary. The nuance these questions test is recognizing that no single fact, like one prior loss, tells the whole story. Only the complete pattern of every past pregnancy turns scattered details into a usable risk profile. When a STEM mentions a prior loss and asks what the nurse most needs, the answer is the complete obstetric history, because the whole pattern of past pregnancies drives accurate risk assessment. Question 39. A nurse is teaching a client about folic acid sources in the diet. Which food should the nurse recommend? Your options are A. Leafy green vegetables, B. Hard candy, C. White rice, D. Butter. Don't overthink it. Which one feels right? The correct answer is A. Leafy green vegetables. A is correct because leafy green vegetables are a rich source of folic acid, which supports early neurologic development and helps prevent neural tube defects during pregnancy. B is wrong because hard candy provides sugar with essentially no folic acid or other nutrients of value in pregnancy. C is wrong because plain white rice is low in folic acid unless it has been fortified, so it is not a strong recommendation. D is wrong because butter is a fat source and does not supply meaningful amounts of folic acid. Folic acid prevents neural tube defects, but knowing where it comes from matters just as much. The name folate even shares a root with foliage, a clue that leafy greens are its richest natural source. Leafy greens like spinach, kale, romaine, and collards lead the list. Legumes such as lentils, chickpeas, and black beans follow, along with citrus fruits, asparagus, broccoli, avocado, and seeds, and fortified grains like bread, pasta, and cereal round out the picture. Folate is the natural form found in vegetables, fruits, and legumes, while folic acid is the manufactured form in supplements and fortified foods. Folic acid actually absorbs a bit more efficiently, but both forms support the cell division and DNA synthesis pregnancy demands. Picture a plate of spinach, kale, and collard greens glowing with concentrated folate. The link between folate and foliage isn't a coincidence, it's a built-in memory cue for where this vitamin lives. When a question asks which food is highest in folic acid, leafy green vegetables are the standout answer, supported by legumes, citrus, and fortified grains. Anchoring on greens gives an easy, memorable way to recommend folate-rich eating. Question 40. A nurse is teaching a pregnant client about food safety to reduce the risk of toxoplasmosis. Which instruction should the nurse include? Your options are A. Drink unpasteurized milk, B. Eat more rare meat, C. Skip washing produce, D. Avoid changing the cat litter box. Got a guess? Lock it in. The correct answer is D. Avoid changing the cat litter box. D is correct because toxoplasmosis can spread through cat feces, so the client should avoid changing the litter box during pregnancy to lower the risk of infecting the fetus. A is wrong because unpasteurized milk can carry harmful organisms and should be avoided during pregnancy. B is wrong because rare or undercooked meat can transmit toxoplasmosis, so the client should eat meat that is thoroughly cooked. C is wrong because washing produce removes possible contamination, so skipping it would raise rather than lower the risk. Toxoplasmosis is a parasitic infection that is usually mild in adults, but can severely harm a developing fetus if a woman is first infected during pregnancy, causing vision loss, brain damage, and other lasting effects. Since there is no simple cure once it crosses to the fetus, prevention is everything. Cats play a central role in transmission because the parasite completes part of its life cycle in them and is shed in their feces, becoming infectious after a day or two. Handling contaminated litter and then touching the mouth or food can pass the parasite to a person. When avoiding the litter box entirely isn't possible, someone else should handle it, or the woman should wear gloves and wash her hands thoroughly afterward. The box should also be changed daily before the parasite has time to become infectious. Cat litter is not the only source. The parasite also lives in undercooked meat, so meat should be cooked thoroughly, and it clings to unwashed produce and soil, so washing fruits and vegetables and wearing gloves while gardening are equally important. When a question asks how to reduce the risk of toxoplasmosis, the key instruction tested is avoiding the cat litter box, alongside cooking meat fully and washing produce well. This is prevention that is far easier than any cure. Question 41. A nurse is reviewing a biophysical profile result that is reported in the normal range. How should the nurse interpret this finding? Your options are: A. Oxytocin should be started. B. It reflects fetal well-being. C. The fetus has a defect. D. Immediate delivery is needed. Which one is it? Pause the video if you need more time. The correct answer is B. It reflects fetal well-being. B is correct because a biophysical profile in the normal range reflects reassuring fetal well-being across the measured parameters, indicating a low likelihood of current fetal compromise. A is wrong because a reassuring profile supports continued monitoring, not the start of labor-inducing medication. C is wrong because the biophysical profile assesses well-being and oxygenation, rather than diagnosing a structural defect. D is wrong because a normal score is reassuring and does not call for immediate delivery. The biophysical profile gives a fuller picture of fetal well-being by combining several measures into one assessment, instead of relying on any single signal. It pulls together 5 components: a non-stress test of the fetal heart rate, plus 4 ultrasound observations, fetal breathing movements, gross body movements, muscle tone, and amniotic fluid volume. Each is scored, usually 2 points if present, for a total up to 10, with 8 to 10 reflecting a healthy, well-oxygenated fetus. The logic is that any single measure can mislead. A fetus in a sleep cycle may move little, making one test look falsely worrisome. Sampling breathing, movement, tone, heart rate, and fluid together smooths out these momentary quirks. Amniotic fluid volume is especially telling because it reflects longer-term placental function. Steady fluid means the fetal kidneys have been well perfused over time, a sign of sustained health rather than a single moment. A normal biophysical profile, generally 8 to 10, is reassuring evidence of fetal well-being, reflecting healthy breathing, movement, tone, heart rate, and fluid together. No immediate intervention needed. Question 42. A nurse is preparing a client for chorionic villus sampling in the first trimester. Which instruction should the nurse provide before the procedure? Your options are A. Avoid drinking any fluids. B. Take a laxative the night before. C. Drink fluids and avoid voiding. D. Remain fasting for the test. Take a second. Which answer would you pick? The correct answer is C. Drink fluids and avoid voiding. C is correct because a full bladder helps position the uterus for the procedure, so the client is instructed to drink fluids and avoid voiding beforehand to improve access and visualization. A is wrong because avoiding fluids would leave the bladder empty, which makes positioning the uterus more difficult. B is wrong because a laxative is not part of preparation and does not aid the sampling or improve safety. D is wrong because fasting is unnecessary, since the test does not involve sedation or contrast affected by food. Chorionic villus sampling, or CVS, is a first trimester test that samples placental tissue called chorionic villi to detect genetic conditions earlier than amniocentesis allows. But the real trick to remembering it is understanding why patient prep is the opposite of what's used later in pregnancy. Early in pregnancy, the uterus sits low and deep in the pelvis, so a full bladder lifts and steadies it, giving the provider a clearer path to the placenta. Later, once the uterus rises into the abdomen, that full bladder only gets in the way. CVS happens between 10 and 13 weeks. So it follows the fill the bladder pattern of the first trimester, unlike second trimester amniocentesis, which calls for an empty bladder. Watch for these signal phrases: chorionic villus sampling, first trimester, and the instruction to drink fluids and avoid voiding. When a question asks what to teach before the procedure, the answer is to fill the bladder. Don't memorize amniocentesis prep and apply it here. Match the preparation to where the uterus sits, and CVS will always mean a full bladder. Question 43. A nurse is teaching a client about quickening during pregnancy. Which description by the client indicates correct understanding? Your options are A. It is a type of contraction. B. It is the first fetal movement felt. C. It is the start of labor. D. It is a cervical change. Before I reveal it, which one do you think is right? The correct answer is B. It is the first fetal movement felt. B is correct because quickening is the first fluttering fetal movement the client perceives, usually felt in the middle of pregnancy, and it is a presumptive sign of pregnancy. A is wrong because quickening is fetal movement rather than a uterine contraction. C is wrong because quickening is early fetal movement, not the onset of labor, which involves regular contractions and cervical change. D is wrong because quickening refers to felt movement, not to softening or dilation of the cervix. Quickening is the first time a pregnant woman feels her fetus move, often described as a flutter, a bubble, or a light tapping, because this feeling is subtle and known only to the woman herself. Quickening belongs to the presumptive category of pregnancy signs, the group based on what she experiences rather than what an examiner can verify. Timing follows a pattern. A woman in her first pregnancy typically notices quickening later, around 18 to 20 weeks, while a woman who has been pregnant before may feel it earlier, around 16 weeks, since she recognized the sensation faster. The same underlying event, fetal movement, falls into different certainty tiers depending on who perceives it. Felt by the mother, it is presumptive. Felt by the examiner, it is positive. Quickening is simply the first fetal movement the mother feels, a reassuring but subjective milestone that confirms nothing on its own. Question 44. A nurse is teaching a pregnant client about relieving leg cramps. Which instruction should the nurse provide when a cramp occurs? Your options are A. Straighten the leg and flex the foot. B. Point the toes downward. C. Massage with cold packs only. D. Stand and bear weight quickly. What's your answer? Commit to one before I continue. The correct answer is A. Straighten the leg and flex the foot. Is correct because straightening the leg and pulling the toes upward toward the head stretches the cramping calf muscle and relieves the spasm quickly and safely. B is wrong because pointing the toes downward shortens the calf muscle and can make the cramp worse rather than better. C is wrong because the key relief is stretching the muscle. Cold packs alone do not release the spasm. D is wrong because standing and bearing weight suddenly during a cramp risks a fall and does not effectively stretch the muscle. Let's look at the mechanics behind that classic leg cramp relief question and why one direction of stretch helps while the other makes things worse. A cramp is the calf muscle locked in a sustained contraction that points the toes downward. To break that spasm, you need the opposite motion, straightening the knee and pulling the toes upward, called dorsiflexion, which lengthens the muscle and signals it to relax. The correct response has three parts: straighten the leg, flex the foot so the toes pull upward, and the stretch releases the spasm. Instinct often leads someone to point the toes or jump up to stand, but pointing the toes shortens the already contracted muscle, and bearing weight suddenly on a cramped calf can be painful and unsteady. So when a question asks how to relieve a leg cramp, remember, straighten the leg and flex the foot upward, because that direction of stretch is what breaks the spasm. Question 45. A nurse is reviewing prenatal laboratory work and notes the client is not immune to rubella. Which action should the nurse anticipate? Your options are A. Give the vaccine during pregnancy. B. Schedule weekly titers. C. Begin antiviral therapy now. D. Plan vaccination after birth. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Plan vaccination after birth. D is correct because the rubella vaccine is a live virus and is not given during pregnancy, so a non-immune client is vaccinated after birth to protect future pregnancies. A is wrong because the live rubella vaccine is avoided during pregnancy due to potential risk to the fetus. B is wrong because weekly titers are unnecessary, since the plan is simply to vaccinate the client in the postpartum period. C is wrong because antiviral therapy is not the approach for rubella non-immunity. Vaccination after birth is the plan. Rubella is usually mild in adults, but if it infects a developing fetus, it can cause devastating birth defects. That's why every pregnant woman gets checked for rubella immunity at her first prenatal visit. If infection strikes early in pregnancy, the virus can cause congenital rubella syndrome, a cluster of severe defects including deafness, cataracts, heart defects, and developmental delays. Because there's no treatment once infection occurs, prevention through vaccination is the only real defense. The rubella vaccine is a live attenuated vaccine, meaning it carries a weakened but living virus. That living quality is exactly why it's never given during pregnancy. Out of concern, it could theoretically affect the fetus. So the plan shifts to right after birth. The vaccine is given before the mother leaves the hospital, since she's confirmed not pregnant at that moment, and she's counseled to avoid conceiving for about 4 weeks while the live virus clears. Breastfeeding is not a barrier, so nursing can continue safely. The key distinction is that live vaccines like rubella are deferred to the postpartum period, unlike inactivated vaccines such as flu shots. Whenever a STEM reports non-immune rubella status, the anticipated action is to plan vaccination after delivery. Question 46. A nurse is caring for a client at 36 weeks of gestation scheduled for Group B streptococcus screening. How should the nurse explain the purpose of this test? Your options are A. It checks the mother's blood sugar. B. It measures fetal lung maturity. C. It screens to protect the newborn. D. It confirms the due date. Which would you go with? Lock it in before the reveal. The correct answer is C. It screens to protect the newborn. C is correct because Group B streptococcus screening identifies carriers so the client can receive antibiotics during labor, which protects the newborn from a serious infection at birth. A is wrong because blood sugar is checked with glucose testing, not the Group B streptococcus culture. B is wrong because lung maturity is assessed through amniotic fluid studies, not a vaginal and rectal culture. D is wrong because the due date is established by menstrual history and ultrasound, not by this culture. Group B streptococcus is a bacteria that lives harmlessly in a healthy woman's vagina and rectum, causing her no illness at all. The real danger is to the newborn, who can be exposed during labor and birth. As the baby passes through the birth canal, it can pick up these bacteria, and in a vulnerable newborn, that exposure can trigger serious infections like sepsis, pneumonia, and meningitis. A swab of the vagina and rectum is collected around 36 to 37 weeks, timed deliberately close to delivery, since colonization can come and go and earlier results would be less reliable. A positive result means antibiotics, usually penicillin, given through the vein during labor, timed exactly when the baby would otherwise be exposed. The mother isn't sick and doesn't need curing. The antibiotics exist purely to shield the newborn during passage through the birth canal. The nuance to remember is that this screen and its treatment exist to protect the newborn, breaking the chain of transmission right at birth. Question 47. A nurse is teaching a client about expected emotional changes in early pregnancy. Which client's statement indicates correct understanding? Your options are A. Mixed feelings early on are common. B. Doubts make me a bad parent. C. Mood swings mean I am unwell. D. Mixed feelings now are abnormal. Don't overthink it. Which one feels right? The correct answer is A. Mixed feelings early on are common. A is correct because ambivalence and shifting moods are common, normal responses in early pregnancy from hormonal and life changes, and they usually ease as the pregnancy progresses. B is wrong because having doubts is a common part of adjusting to pregnancy and does not reflect on the client's ability to parent. C is wrong because mood swings reflect normal hormonal shifts rather than illness. D is wrong because mixed feelings early in pregnancy are a typical response, not an abnormal one. Even in a wanted planned pregnancy, a woman can feel joy and fear at the same time. This mix of positive and negative feelings is called ambivalence, and it's a completely normal part of early pregnancy. Several forces drive these emotional swings. Steep hormone changes affect mood intensely, while pregnancy reshapes identity, relationships, finances, and the future. So the mind naturally works through a transformation this large, and feeling unsettled simply reflects that real processing. Picture a nurse talking with a newly pregnant woman who sheepishly admits she feels both thrilled and terrified. The nurse reassures her that this is common, explaining that hormones and the sheer scale of life change both play a role, easing a worry she was afraid to voice. Understanding ambivalence as normal protects a woman from unnecessary guilt and opens honest conversation with partners and family. But there's a boundary. Ordinary mixed feelings come and go, while persistent sadness, hopelessness, or an inability to function can signal depression and need evaluation. The sound answer recognizes ambivalence as normal, not an expectation of constant joy. Mixed feelings, not uniform happiness, are the healthy sign of a woman processing a major life change. Question 48. A nurse is teaching a client at 32 weeks of gestation about warning signs to report. Which symptom should the nurse instruct the client to report to the provider immediately? Your options are A. Occasional painless practice contractions. B. Increased clear vaginal discharge. C. Mild swelling of the feet. D. Severe headache with blurred vision. Got a guess? Lock it in. The correct answer is D. Severe headache with blurred vision. D is correct because a severe headache with blurred vision can signal gestational hypertension, a serious complication. So the client should report these findings to the provider without delay. A is wrong because occasional painless practice contractions are normal and usually ease with walking or position change, so they need no urgent report. B is wrong because an increase in clear vaginal discharge is expected in pregnancy, unlike a sudden gush of fluid, which would need evaluation. C is wrong because mild foot swelling at the end of the day is a common late pregnancy discomfort rather than a warning sign. In the third trimester, a severe headache paired with blurred vision is a red flag your body sends when something serious may be happening. That pairing is a classic sign of preeclampsia, a condition of dangerously high blood pressure that strains the mother's organs. The headache comes from pressure on the brain's vessels, while blurred vision or flashing lights come from that same pressure affecting the tiny vessels of the eyes. Preeclampsia often shows other clues too: swelling of the face and hands, sudden weight gain from fluid retention, and pain under the ribs where the liver sits. But headache with vision changes is the combination that most urgently signals worsening disease. The key is telling ordinary late pregnancy discomfort apart from true danger. Mild swelling and fatigue are expected, but a severe headache with blurred vision is categorically different, since it can mean preeclampsia progressing toward eclampsia, seizures that threaten mother and baby. Whenever a severe headache meets visual changes in the third trimester, that combination demands an immediate call, not watchful waiting. Question 49. A nurse is teaching a client about using a fertility awareness method to avoid pregnancy. Which instruction should the nurse include about the fertile period? Your options are A. Fertile days stay the same monthly. B. Have intercourse only during menses. C. Avoid intercourse during fertile days. D. Charting one cycle is enough. Which one is it? Pause the video if you need more time. The correct answer is C. Avoid intercourse during fertile days. C is correct because to avoid pregnancy with a fertility awareness method, the client abstains from intercourse during the fertile window, when an ovum and sperm are most likely to meet. A is wrong because fertile days shift when cycle length varies, so the client cannot assume the same days from 1 month to the next. B is wrong because limiting intercourse to menses is not the safeguard. Avoiding the fertile days around ovulation is what lowers the chance of pregnancy. D is wrong because dependable timing requires charting several cycles, since a single cycle does not reveal the client's usual pattern. Fertility awareness means avoiding pregnancy naturally by identifying the fertile days and abstaining from intercourse during that window. An egg survives only about 24 hours after ovulation, but sperm can live in the reproductive tract for up to 5 days when fertile mucus is present. That means intercourse days before ovulation can still lead to pregnancy, stretching the danger zone backward. The fertile window therefore spans roughly the 5 days before ovulation, plus the day of ovulation itself, because sperm survival extends the risk period well before the egg even appears. Since ovulation can't be seen directly, fertility awareness combines signals. Tracking cycle length predicts timing. Observing clear, stretchy cervical mucus signals approaching fertility, and measuring basal body temperature confirms ovulation already happened. Using several indicators together is more reliable than relying on just one. The key nuance is that the fertile window lasts several days because sperm can survive that long, so couples must avoid intercourse across the entire stretch, not just the single day of ovulation. Question 50. A nurse is teaching a pregnant client about foods that are high in calcium for bone and teeth development. Which food should the nurse recommend? Your options are A. Apples, B. Yogurt, C. Potato chips, D. White bread. Take a second. Which answer would you pick? The correct answer is B. Yogurt. B is correct because yogurt is a rich source of calcium, which supports the bone and teeth development of the fetus and helps the client meet her increased needs during pregnancy. A is wrong because apples offer fiber and some vitamins but contain very little calcium, making them a weak choice for this purpose. C is wrong because potato chips are high in fat and salt while providing minimal calcium and few useful nutrients during pregnancy. D is wrong because plain white bread is mainly carbohydrate and supplies little calcium, so it does not meet the client's needs for this mineral. Pregnancy places heavy demands on calcium because the fetus needs it to build bones and teeth, and if the mother's intake falls short, her own body will divert calcium to protect the baby. Dairy foods, especially yogurt, are prized because they deliver a large amount of calcium per serving, in a form the body absorbs efficiently. Yogurt also offers protein and live cultures, making it easier for some women to digest than milk, helping meet the roughly 1,000 milligrams needed daily. For women who avoid dairy, calcium can still come from fortified plant milks and orange juice, canned fish like sardines and salmon, calcium-set tofu, and leafy greens such as kale and collards, though absorption varies and a larger variety or a supplement may be needed. Picture calcium moving from the mother's diet toward the developing fetal skeleton, with any shortfall pulled straight from her own bone stores to protect the baby's bones and teeth. When a question asks which food is highest in calcium for bone and teeth development, a dairy source like yogurt is the concentrated, well-absorbed go-to recommendation. That wraps up our question and answer review for Section 1, Antepartum Care. If you'd like more practice covering everything we just went over, be sure to check out our website. You'll find the link right in the description below. Once you're there, you'll discover hundreds of free practice questions, plus complete study guides covering every topic we've discussed, all available and ready whenever you need them. Subscribe so you don't miss the next part, and good luck on your exam.